Welcome back to MLT 120 again. This is part 2 of the other white blood cell diseases lecture. We're going to start off by talking about lymphomas. Okay, the first lymphoma that we're going to talk about is the Sézary syndrome. And the Sézary syndrome is a symptomatic leukemic phase of cutaneous T-cell lymphoma. So let's talk about what does that mean. Okay, let's talk about leukemic. What does leukemic mean? Leukemic is referring to cancer of blood-forming tissues like the bone marrow. And cutaneous is referring to or relating to skin tissue. So the first phases of Sézary syndrome is going to be affecting the cells in the skin tissue. So the first stages of Sézary syndrome can start as what we call mycosis fungoides, or MF. And this is a chronic skin cancer that can spread to other parts of the body in later stages. And then finally it will develop into Sézary syndrome. And you can see some of the, or an example of what the mycosis fungoides looks like on the skin in this image right here on the top left hand side of your slide. Now you will see circulating abnormal lymphs called Sézary cells, and these are your T lymphs or your T cells, and they usually have the cluster destination of CD4. Okay, sometimes in rare occasions they can have the cluster destination of CD8, but most of the time they will have that cluster destination of CD4. For your T-cell lymphocytes that are affected with this syndrome, they're usually your small lymphocytes. And you can see some Sézary cells here, for example. They have something or a formation, what they refer to as the cerebriform nucleus. And this is basically where they say the nucleus resembles what looks like a little brain. The nucleus looks like a brain formation. And this is a good example of the nucleus looking like a little brain or brain tissue. The diagnosis for this disease is usually a skin biopsy, and in that skin biopsy you have an accumulation of abnormal lymphs. In addition to the biopsy, a immunologic marker test can be performed to help diagnose a patient with Sézary syndrome. This slide is just to demonstrate some of the symptoms that go along with the Sézary syndrome. Of course, earlier on in the disease, the skin's going to be more affected. The skin is going to be red or have a rash. It can be itchy, peeling, and painful. There also can be hair loss involved. Thickening of the skin on the palms of the hands and soles of the feet can also be a symptom. Variable amounts of scaling on the skin, abnormalities of the fingernails and toenails, and the lower eyelids can be turned outward. And of course, on a microscopic level, you would see the abnormal T-cell lymphocytes. Now let's do a few questions to review the Sézary syndrome. I would suggest you pausing the video at this time and try to answer these on your own before you move forward in the video and I give you the answers. Okay, first question is describe the appearance of the Sézary cell. Okay, you're going to have your T lymphocytes. They're going to be small. They're going to be non-reactive. And of course, you can have that cerebral form of the nucleus in those small T lymphocytes. Remember that cerebral form is where the nucleus kind of appears to be like a little brain. Next question is what type of specimen is used to diagnose Sézary, typically earlier in the course of the condition? The answer would be a skin biopsy, and you're looking for abnormal T lymphocytes. The last question is, which condition is symptomatic or is the symptomatic form? The MF, the mycosis fungoides, or the Sézary syndrome? The answer would be the Sézary syndrome, because once it's spread to other areas other than just the skin, it would be Sézary syndrome. The next lymphoma we're going to discuss is Hodgkin's lymphoma, and this is a cancer of the lymphatic system. And this one is affecting the B cells. So it's a B cell lymphoma where the Sézary was affecting the T cells. This one's affecting the B cells. There's two forms. There's the classic Hodgkin's lymphoma, and then there's the lymphocyte predominant Hodgkin's lymphoma. So about 95% of the cases are made up of classic Hodgkin's lymphoma, meaning that the lymph nodes are being affected, or the lymphatic system. So with the classic Hodgkin's lymphoma, it's usually diagnosed by lymph node or tissue biopsies, and we look for what we call a Reed-Sternberg cell, which is a bilobed or multilobed nucleated cell with an abundant cytoplasm, and it has the cluster destination of 30 as the immunophenotyping marker. So you'll see over here on the top left-hand side of your slide an image that's demonstrating a Reed-Sternberg cell. It's got a comparison of a normal lymphocyte and a Reed-Sternberg cell, so you can see a comparison. You can see the size difference. You can see the bilobed or multilobed nucleated cell versus the mononucleated normal lymphocyte. The Reed-Sternberg cells are almost never found in peripheral blood. We're usually going to find these in bone marrow. This is a non-painful lymph node swelling. So once the lymph nodes are swelled up, it's usually not painful. And usually there's what we call a bimodel as far as when this shows up in patients. It usually either peaks at ages 15 to 35 or at age groups of people over 50. So this slide is just going over some symptoms and some signs of Hodgkin's lymphoma. Of course, your lymph nodes are going to be involved. It also can affect lungs, cause coughing. You could have liver enlargement, also kidney involvement. Patients might have night sweats. They could have itchy skin, spleen enlargement, and of course the bone marrow is going to be affected because that's where we're going to see those Sternberg cells for diagnosis. Okay, let's do a few practice questions for Hodgkin's lymphoma. Again, pause the video at this time and try to answer these on your own before you continue to play the video and I answer the questions for you. Name the characteristic cell found in lymph node biopsies of Hodgkin lymphoma patients. Of course, that would be our Reed-Sternberg cells. Then the second question is list the bimodal age peaks that Hodgkin lymphoma occurs in. And the two age groups would be ages 15 to 35 and then patients that are over 50 years of age. Burkitt's lymphoma is up next. This is a B-cell cancer. The Burkitt's lymphoma epidemic mostly affects children in Africa and New Guinea. It usually affects the jaw and facial bones. In patients with this lymphoma, you usually see what we refer to as Burkitt's cells in the bone marrow, and they are or have what we refer to as a starry sky appearance. And you can see an example on the lower left-hand corner of the slide. These little dots that are on your cells or in your cells in the cytoplasm are what makes up the starry sky appearance. You can see some more images in your atlas for the Burkitt's lymphoma. Also, if you'll look up here in the top left-hand corner, you can see how the disease affects the jaw and facial bones of a patient with Burkitt's lymphoma. We have a couple of review questions. Again, I would suggest pausing the video and try to answer them on your own before you continue to play the video and I give you the answers. The first question is name the area and the age group you will see Burkitt's lymphoma occur. And the age group would be mostly in children, and the area would be in Africa and New Guinea. Second question is describe the appearance of the Burkitt cells. They have that telltale look of a starry sky appearance in the cytoplasm under the microscope. The next disease we're going to discuss is multiple myeloma, also known as MM for short. This is a B-cell plasma cell abnormality, and this is a proliferation in the marrow. Proliferation meaning there's a rapid reproduction of cells. There's an overproduction of immunoglobulins. Remember, immunoglobulins you can use interchangeably with antibodies. So there's an overproduction of antibodies. Also, this is a lytic bone disease. Lytic meaning there's bone breakdown or bone weakening. It even allows lesions or holes to form in bones. When we're dealing with multiple myeloma patients, we have what we call Russell bodies form in the cytoplasm of plasma cells, and we also have what we refer to as flame cells form in patient samples. So if you'll look over to the top left-hand corner, you'll see an example of what a Russell body looks like in a plasma cell. The arrow is pointing to a Russell body. Okay, this is a cytoplasmic inclusion, and it's filled with antibodies. Remember, we have an overproduction of antibodies or immunoglobulins. The flame cell, you see an example on the lower left-hand corner. The flame cell are plasma cells which have a distinctive pinkish hue in the outer rim of the cytoplasm, and the appearance is throughout and can be a result of participated immunoglobulins or antibodies. These cells can be found in plasma cells, and on the CBC, usually these patients present to be anemic. Also, on multiple myeloma patients, you may see Rouleau on the slide. The ESR tends to be increased. This is due to abnormality of high levels of proteins and increased inflammation. One thing we look for in multiple myeloma patients is a Bence-Jones protein. This is a light chain antibody or immunoglobulin, and it is not normally found in the urine, but if we do find it in urine samples, it is an indicator that a patient might have multiple myeloma. And about 2/3 of multiple myeloma patients will have Bence-Jones protein in their urine. And overall, a multiple myeloma, their bone marrow sample, you will see increased plasma cells. So this image is to demonstrate the difference between what healthy bone marrow looks like versus a patient with multiple myeloma, what their bone marrow would look like. So let's first look over here on the left-hand side at the normal healthy person's bone marrow. You have plasma cells and normal antibodies in a regular number or a regular count. You wouldn't have too many of anything. You'd have just the right amount. But something happens in the multiple myeloma patient. There's an abnormal change. There's a neoplastic transformation of plasma cells of the B lymphocyte line. and there is a proliferation or an uncontrolled proliferation of myeloma cells. Remember, your B lymphocytes give rise to your plasma cells, and your plasma cells produce antibodies. So if your B lymphocytes and your plasma cells are abnormal, then most likely your antibody production is going to be abnormal. So that's what these multiple myeloma patients are facing. We've got abnormal overproduction of plasma cells. We've got abnormal and overproduction of antibodies. So what are some symptoms that go along with multiple myeloma? Of course, we've mentioned already before that you will see anemia most likely on your CBC. These patients can also suffer from fatigue, weight loss, also decreased kidney function, and also back pain and pain in the ribs and back. All right, let's do some practice questions for multiple myeloma. Again, I would suggest you pausing the video at this time before we go through these questions and answers in the video. First question, is multiple myeloma a B or T cell proliferation? The answer is it is a B cell proliferation. Question 2, name a common finding in a peripheral smear of a multiple myeloma patient. A inclusion would be the Russell bodies, and also you could see flame cells. Number 3, why is the ESR increased in patients with multiple myeloma? It's because the patients usually tend to have an increase in proteins, and also there's inflammation present in patients with multiple myeloma. Next question, what cells will soon be in abundance in the bone marrow of a biopsy from a patient with multiple myeloma? Of course, you will see plasma cells. Next question, does multiple myeloma cause bone lesions? Yes, because it weakens the bones. Last question, name abnormal proteins found in urine of multiple myeloma patients. You would find most likely the Bence-Jones protein. The last disease that we're going to cover is Waldenstrom's macroglobulin anemia. This is a type of non-Hodgkin's lymphoma. It's described as a malignant lymphoproliferative disorder. It's a disease characterized by uncontrolled production of lymphocytes. You will see what's called plasmacytoid lymphs in the bone marrow. These are cells that resemble or are derived from the plasma cells. You will have no lytic bone lesions like in multiple myeloma. These patients will produce IgM monoclonal antibodies, and these antibodies will cause an increase in blood viscosity. So the blood will be thicker, so it will be known to be hyperviscosity. And the median age for diagnosis is 64 years of age. Okay, our last slide is just a few practice questions that go along with Waldenstrom's disease. If you want to, pause the video at this time and try to answer them on your own before we go over the answers. The first question is, what class of macroglobulins or antibodies do the cells of Waldenstrom's patients produce? They produce IgM antibodies. Second question, describe the viscosity of the plasma for a Waldenstrom patient. The patient would have thicker or hyperviscosity for their blood. Number 3, what is the median age for diagnosis for a patient with Waldenstrom's disease? The median age would be 64. This concludes our lecture on other white blood cell diseases. If you have any questions, please don't hesitate to reach out, or you can ask questions during our lab time.